Good afternoon, everyone. My name is Kyle Brown. I'm the Bite-Size Lecture Coordinator for the Southeast Chapter of SCCM. On behalf of our speakers and our Executive Board, I would like to say thank you for joining us today for our quarterly Bite-Size Lecture. Before I introduce our speakers, I would like to begin our session with reading of the Southeast Chapter SCCM mission statement, which is to emulate SCCM's mission, which is to secure the highest quality of care for all critically ill and injured patients in the Southeast region by providing educational and research opportunities, as well as promoting multi-professional collaboration. With that, I would like to welcome our speakers from Wellstar MCG Health Medical Center. We have Marylee Brehmer, Ashley Taylor, and Dr. Shaynna Mann. And on that note, I will hand it over.
Okay, so I'm Marylee. I'm one of the PAs with CT surgery, and I work in the ICU at Wellstar MCG. So today we're going to talk about vasoplegia after cardiac surgery. So as we know, there are different types of shock, including obstructive, hypovolemic, cardiogenic, and distributive shock. And vasoplegia is a specific type of distributive shock. So vasoplegia in cardiac surgery, it accounts for about less than 5% of all circulatory shock. And in those who have cardiac surgery, the incidence of developing it ranges from about 5% to up to 50% in these patients. So in this population, the mortality rate can be as high as 25%. And these patients are at a higher incidence of organ dysfunction and a prolonged length of ICU stay, whether it be to them requiring pressors or prolonged mechanical ventilation. It just depends on the patient. So in patients who are having cardiac surgery, both preoperative and intraoperative risk factors play a huge role in the development of postoperative vasoplegia. So different preoperative risk factors are patients with an ejection fraction less than 40%, those who are of advanced age, patients with baseline renal dysfunction, renal failure, diabetics, and the use of ACE inhibitors. However, that topic does remain controversial. Intraoperative risk factors include patients who are having reoperation, combined surgery rather than your isolated CABG or valve, prolonged cardiopulmonary bypass time and aortic cross-clamp time, requiring multiple transfusions and placement of ventricular assist devices. So of course, these risk factors, the more the patient has, the higher incidence of them getting postoperative vasoplegia. So there's no standard definition of vasoplegia. However, in general, it's thought to be related to refractory hypotension, so a mean arterial pressure less than 65, that's not responding to your volume resuscitation, a low systemic vascular resistance less than 800, and a normal cardiac index greater than 2.2. And the onset timing of vasoplegia is thought to occur within less than 24 hours after a cardiopulmonary bypass. So clinically, when we look at a patient, we refer to vasoplegia as a high output shock state. So again, having that low systemic vascular resistance, the normal or high cardiac index, cardiac output. So it's not actually the heart that's impaired, it's the vasculature that's dysregulated, dysfunctional, causing that vasodilation and ultimately the hypoperfusion. So getting into the physiology and pathophysiology of vasoplegia, I'm going to just start by explaining how our body normally responds to hypotension. So normally our vasculature responds to hypotension by activating G protein coupled receptors. So your alpha receptors activated by catecholamines, your vasopressin receptors activated by vasopressin, and your angiotensin receptors activated by angiotensin 2. And these receptors cause an increase in intracellular calcium of the vascular smooth muscle cells, which causes vascular smooth muscle cells to contract, leading to vasoconstriction and increasing your blood pressure. However, following cardiopulmonary bypass, this normal physiology is disrupted, which can then lead to vasoplegia. So vasoplegia can be mediated by nitric oxide production, adrenal receptor desensitization, and depletion of plasma vasopressin, excess production of hydrogen sulfide, and dysfunction of the renin-angiotensin system. So the first mechanism to discuss is nitric oxide production. So a systemic inflammatory response is triggered by multiple factors both during and post cardiopulmonary bypass, including exposure of blood to the bypass circuit, surgical trauma, release of endotoxins from the gut, and ischemia and reperfusion injury. And all these cause a release of inflammatory cytokines, which are your interleukin-1, interleukin-6, and tumor necrosis factor alpha. And these inflammatory cytokines induce nitric oxide synthase, which increases the production and release of nitric oxide. And nitric oxide has two main effects that result in vasodilation. So the first main effect of nitric oxide is activating soluble guanylate cyclase and vascular smooth muscle cells, which increases the production of cyclic GMP, which causes the myosin light chain dephosphorylation, leading to vasodilation. And the second main effect of nitric oxide is activation of adenosine triphosphate sensitive potassium channels in vascular smooth muscle cells. So it inhibits calcium influx in the smooth muscle cells by hyperpolarizing the membrane potential, resulting in vasodilation. Actually, go back one. So the second mechanism behind vasoplegia is through the adrenergic system. So following cardiopulmonary bypass, cytokine release, and sustained baroreceptor stimulation, it triggers this overactivation of the central sympathetic system and the hypothalamic pituitary axis. And this results in a desensitization of the receptors due to the excessive increase in these vasoconstrictive mediators, with a subsequent depletion due to the persistent shock state and hypotension. And the reduction of plasma vasopressin is thought to be related to nitric oxide production, because nitric oxide inhibits vasopressin release. So like mentioned previously, nitric oxide release causes activation of the potassium ATP channels, which causes an inhibition of vasopressin effects due to the membrane hyperpolarization and reduction in calcium influx into the cells. Therefore, it limits the cellular response to vasopressin. The third mechanism behind vasoplegia is possibly mediated by hydrogen sulfide. However, it hasn't been directly demonstrated in the setting of bypass, but we can assume that with the extensive inflammatory conditions that our body undergoes in response to bypass might enhance the production of hydrogen sulfide. So the mechanism behind this is hydrogen sulfide is produced from L-cysteine, and this agent acts on the potassium pump in the cells, causing that membrane hyperpolarization and inhibiting calcium influx, therefore decreasing contraction and causing vasodilation. And lastly, we have dysfunction of the renin-angiotensin system. So in a normal pathway, angiotensinogen is converted into angiotensin 1 by renin, and then to angiotensin 2 by type 1 angiotensin converting enzyme. That's in the lung endothelium. And then angiotensin 2 targets the vascular AT1 receptor, which causes the increase in cytosolic calcium and vasoconstriction. So in situations where ACE activity is impaired, angiotensin II formation is prevented or disrupted. So for example, patients with lung injury, and it's also thought that in the setting of cardiopulmonary bypass, due to the exclusion of pulmonary circulation, can disrupt this pathway. So when this pathway is disrupted, it stimulates the kidneys to produce more renin, and this shunts this metabolic pathway into a secondary metabolism to produce these angiotensin metabolites, which are your angiotensin 1,9 and angiotensin 1,7. And these act on the AT2 receptor, which is associated with vasodilation. And then these are my references.
Thank you so much, Marylee. My name is Ashley. I'm a critical care pharmacist at Wellstar MCG Health in Augusta, Georgia, and I work in the cardiothoracic intensive care unit. And now we're going to talk through the management of vasoplegia after cardiac surgery and some of the data behind the agents that we use. So really the first step of management to vasoplegia after CT surgery is volume optimization. Patients should receive a volume challenge prior to moving on to catecholamine agents. And once a patient has failed a volume challenge, then at that point, you can consider moving on to your catecholamines. And they're really considered first-line therapy for patients that have significant hypotension after CT surgery. Regarding the catecholamines themselves, there's not a lot of data to specifically support one agent over the other. However, we can extrapolate from sepsis data since the pathophysiology is similar. Patients typically will receive norepinephrine as the first-line agent, kind of extrapolating that data from sepsis data. And it provides a lot of alpha-1 agonism, so it can really help us with patients that have a low SVR. Catecholamines can have undesirable effects at high doses, like dysrhythmias or increased myocardial oxygen demand. So we try to avoid reaching high doses of these agents. Vasopressin is an excellent second-line agent, and it is recommended second-line for patients that are in septic shock, kind of similarly to this. So as Marylee kind of already mentioned, patients that are post-cardiopulmonary bypass can have reduced vasopressin levels in the body. And so really vasopressin can be a great agent for us to use second line. You can use vasopressin at higher doses than are recommended for septic shock in patients that are experiencing vasoplegia after CT surgery. But you would just want to be mindful that you can get mesenteric ischemia and other peripheral ischemia and things like that at high doses of vasopressin. So vasopressin can be particularly useful in patients that have catecholamine resistance after cardiopulmonary bypass, which is really common to happen. So the definition is kind of a bit debated. It typically is defined as a reduced systemic vascular resistance with a normal or increased cardiac output and an inability to obtain appropriate MAP despite therapy with catecholamines. And the part that's kind of not well established is exactly what dose of norepinephrine or norepinephrine equivalent should we be starting additional agents, or will we classify this as catecholamine resistance? But typically that number kind of falls somewhere between 0.2 and 0.5 max per kilogram per minute. Catecholamine resistance after bypass is associated with worsened outcomes. So it's associated with an increased risk of mortality and an increased risk of renal injury. And the mechanisms of this resistance that are proposed are kind of similar to the ones that Marylee already spoke to, but you can get an upregulation of nitric oxide, further reducing your catecholamine activity. You can have oxidative stress and a superoxide upregulation, which causes a deactivation of endogenous catecholamines. Altered alpha-1 receptor expression can also occur, kind of reducing the activity of catecholamines as well. And then we can have dysfunction of the RAS system. So after vasopressors, there are some other adjunctive agents that we can use to help us achieve appropriate blood pressure goals in this patient population. And the first adjunctive agent that we're going to talk about is methylene blue. Methylene blue primarily works directly on the nitric oxide pathway, by inhibiting nitric oxide synthase and reducing the production of nitric oxide, which further reduces the vasoplegia or the vasodilation that's happening due to the potent vasodilatory effects of nitric oxide. It also works by competing with guanylyl cyclase directly, which interrupts the production of cyclic GMP. The dosing for methylene blue for this indication, you could do it a couple of different ways. Studies have done it using a bolus, so 1 to 2 milligrams per kilogram IV bolus, typically given every 30 minutes. And you can also consider following that up with a continuous infusion. A couple of contraindications to keep in mind. So methylene blue is serotonergic, and it's contraindicated or not recommended to be used with other serotonergic agents like SSRIs, NRIs, or MAOIs. And then it's also contraindicated to patients that have a G6PD deficiency. Some notable adverse effects are discoloration of the urine and also the skin. So it can cause a blue tint of the urine and skin. And then at high doses, you can get methemoglobinemia and also CNS depression. The data behind methylene blue for vasoplegia after CT surgery is not the most robust data. There have been a lot of case reports and small case series supporting the use of methylene blue for this indication, and there have been some smaller studies that have come out looking at its use for this indication. So the first one that we're going to talk about is Levin and colleagues, and that was a randomized controlled prospective study that looked at patients who underwent CT surgery with cardiopulmonary bypass and developed vasoplegia. They compared methylene blue 1 milligram per kilogram, 1.5 milligram per kilogram over an hour versus placebo, and they actually found that there was a reduction in mortality and a faster time to shock resolution. So they found that the majority of patients had their shock resolved by about 2 hours in the methylene blue group compared to about 48 hours in patients who had received no intervention. Mahaffey and colleagues did a retrospective study, and they were kind of looking to see what timing would be the most appropriate to give methylene blue in this patient population. And so they looked at adult patients who had undergone CT surgery, and they compared early administration to late administration of methylene blue. And early administration, they were giving methylene blue in the OR, compared to late was once the patient made it to the ICU. Their primary outcome was major adverse events, and they found that there were less major adverse events in the patients that received methylene blue early, and they found that there was a reduction in operative mortality and then also a reduction in renal failure. So kind of some thought-provoking could potentially be an option for us for this indication. Another agent that works similarly to methylene blue is hydroxycobalamin, which is a precursor to vitamin B12. It works as a scavenger for nitric oxide production and leads to a reduction in vasodilation caused by nitric oxide. And then similarly to methylene blue, it also inhibits guanylyl cyclase, which reduces cyclic GMP. A bit different than methylene blue, it also binds directly to hydrogen sulfide, and thus reducing the downstream effects of hydrogen sulfide, so then further reducing patients' vasodilation. Unfortunately, it's on shortage, so we're not using this as an agent right now, but if we did have it, we would be dosing it 5 grams IV bolus, and then you could repeat that dose after about 30 minutes or so, an hour or so, if you didn't achieve appropriate MAP goals. Kind of similarly to methylene blue, hydroxycobalamin also discolors the urine, so it can turn your urine red. The literature for hydroxycobalamin by itself is really very sparse. There's very little data out there to support its use for vasoplegia after CT surgery. There are a lot of case series and case reports that are out there, but very few randomized controlled trials. Shaw and colleagues did a retrospective single center chart review looking at patients who had received hydroxycobalamin and after CT surgery. And they included about 30 patients. And so they found, they kind of were looking at to see, they divvied up the groups as people that have responded to methylene blue compared to, or to hydroxycobalamin compared to those who had not responded. And they found initially that most patients responded to hydroxycobalamin equally, about 25%. But after that first initial 20 minutes, that patients that were in the responders group had a significant reduction in their norepinephrine requirements. So potentially could be a useful option. However, this study really showed that there was a heterogeneity in patient response to hydroxycobalamin. Block and colleagues did a single center retrospective case series in patients that had received hydroxycobalamin, and they found that there was about a 10-point increase in patients' MAP after hydroxycobalamin use, and that the patients that received hydroxycobalamin had a reduction of about 20% after in their vasopressor requirements after administration. There have been studies that have kind of looked to see which of the two agents would be the most beneficial after CT surgery. So this study was a study that was done in people that had undergone CT surgery and received either methylene blue or hydroxycobalamin. The hydroxycobalamin was dosed as a 5-gram bolus, but the methylene blue could be given as a bolus with or without continuous infusion afterwards. Their primary outcome was looking at the change in vasopressor requirements at 24 hours. And they had several secondary outcomes. They were looking at the change in MAP, SVR, and serum lactate, as well as hospital and ICU length of stay, and then patient mortality. They included 120 patients, so pretty large study. And there were about 40 patients in the methylene blue group and then 70 patients in the hydroxycobalamin group. So to orient you to this slide, the solid line is the patients that received hydroxycobalamin, and then the dotted line is patients that received methylene blue. Whenever you look at the patient's norepinephrine requirements over time, they found that patients that received hydroxycobalamin actually had a lower norepinephrine requirement over time. However, they were in that group starting out at a lower requirement as well. And then patients also had an increase in their mean arterial pressure and ultimately had a higher pressure than patients that were in the methylene blue group. There were no differences in their serum lactate or in their systemic vascular resistance, and really no differences were seen in hospital or ICU length of stay or mortality. So this study determined that there was a greater reduction in vasopressor requirements in patients that received hydroxycobalamin compared to methylene blue. However, I think there are some significant limitations to this study, and it would be beneficial for us to have more data for to really determine which of these agents would be best. Kind of the new hot drug on the market for vasoplegia after CT surgery is angiotensin II or Giapreza. Angiotensin II is a synthetic form of your endogenous angiotensin II, which is naturally occurring hormone in the RAS system. It increases your blood pressure via activation of the angiotensin II type 1 receptors or AT1 receptors and causes subsequent vasoconstriction and aldosterone release. The dosing is given as a continuous infusion, and so the dosing is typically 10 to 80 nanograms per kilogram per minute. And after the first 3 hours, it's typically recommended to reduce your maximum dose to 40 nanograms per kilogram per minute. And some important considerations are the risk of thrombosis with this drug. So both arterial and venous thrombosis has occurred in the literature. So it's typically recommended that patients receive VTE prophylaxis, particularly if they're going to be on this medication. The big study that brought this drug to market was the ATHOS-3 study. And so it looked at the use of angiotensin II in patients that had vasodilatory shock. So this was a large multi-center randomized controlled placebo-controlled double-blind study, and it looked at adult patients with vasodilatory shock despite appropriate volume resuscitation in patients who are requiring high dose of vasopressors, which they determined to be norepinephrine equivalent of 0.2 mics per kilogram per minute. So the vast majority of these patients were actually septic shock patients, but there were a small subset of patients that were included that had vasodilatory shock after cardiac surgery. Patients received angiotensin II that was titrated to a MAP of 75 or greater compared to placebo. The primary outcome was a MAP response at 3 hours, and then some secondary outcomes were changes in SOFA score, in vasopressor dose, and then 7 and 28-day all-cause mortality. For their primary outcome, they did see a MAP response at 3 hours in the angiotensin II group compared to placebo. But however, they didn't see a difference in mortality at 7 or at 28 days. As I mentioned, VTE is really common, or is one of the more common adverse effects associated with angiotensin II. This study found that there was about a 2% rate of DVT. So as I mentioned, there were some CT surgery patients that were included in this study. And so there was a post-hoc analysis of this patient population from the previously mentioned AETHOS-3 study. So this study included patients that had presented with vasoplegia after cardiac surgery requiring cardiopulmonary bypass. And the number of patients was 16. And so there were 9 patients in the angiotensin II group compared to 7 in the placebo group. Some important baseline characteristics is that about 20% of patients had a baseline MAP of less than 65, and their median norepinephrine dose was 0.29 micrograms per kilogram per minute. The majority of patients did actually have vasopressin on board at the time of randomization. So similarly to the AETHOS-3 study, they found that the MAP goals were met at hour 3 in the patients that received angiotensin II, but they also didn't find a difference in mortality. And they found that there were no thrombotic complications in this subset of patients. However, there were only 16 patients included. So angiotensin II could potentially be another additional or alternative agent for us to use for the management of vasoplegia. There has been another small study that's come out recently looking at angiotensin II following cardiac surgery. And so this was a single center retrospective observational study that looked at patients who had had vasoplegia after CT surgery requiring bypass that was refractory to standard of care treatments. And these patients received angiotensin II. The primary outcome was their mean arterial pressure response at 3 hours. And then they had some secondary outcomes looking at norepinephrine and other vasopressor doses, mortality, and then safety outcomes. There were 30 patients that were included in this study, and 30% of those patients had a valve repair or replacement as their surgery type, and then 17% of patients had a CABG. The majority of patients did receive cardiopulmonary bypass, and the mean bypass time was 110 minutes. 50% of the patients did also receive mechanical circulatory support after surgery. For their primary outcome, looking at MAP response at 3 hours, they found that there was a 10-point increase in the MAP at 3 hours, and they found that at the 3-hour mark, the 90% of the patients had a MAP that was greater than 65. The risk of mortality, or the incidence of mortality at 28 days was 43% of patients, and about 17% of patients did actually develop a thrombus. There was a significant reduction in the norepinephrine requirements. So in this yellow box, in the light yellow box, you can see that that was the norepi dose at the initiation of angiotensin II, and then you can see that it reduced over time until angiotensin II was discontinued. So there are some other adjunct therapies that I did want to briefly mention. So stress dose steroids are widely used for the treatment of vasoplegia after CT surgery. There's not a lot of data specific to CT surgery. However, we can extrapolate from a plethora of data of hydrocortisone use after in patients that have septic shock. So typically, hydrocortisone is dosed the same way that it would be for septic shock. at 200 milligrams a day or 50 milligrams every 6 hours. Ascorbic acid is another agent that has been studied for vasoplegia. It's been studied in septic shock patients as well, and so the Levitt study actually found an increased risk of mortality in patients that had septic shock. There has been a small study done in patients that had CT surgery or vasoplegia after CT surgery and found that there wasn't an increased risk of mortality, but also that ascorbic acid did not achieve a faster resolution of vasoplegia. So I did kind of want to give a summary of recommendations, and this is currently what we're doing at WellStart NCG Health. We have an institutional guideline. This is kind of a snippet from that, but we typically treat it like a stepwise approach. So for patients that have had CT surgery requiring bypass, if they are resistant to catecholamines, so we define that at our institution as a norepinephrine or norepinephrine equivalent of 0.2 micrograms per kilogram per minute. We're adding on vasopressin. Once we get to a vasopressin of 4 units per hour or more, that's when we start looking for some of these other agents. So if we're unable to achieve our goal maps despite norepinephrine and vasopressin, we're typically at that point reaching for steroids as well. And then at that point, we can consider a dose of methylene blue, or if the patient has a contraindication to methylene blue, we either can do angiotensin 2 or hydroxycobalamin if we have that in stock. And then after that, we typically have angiotensin 2 as our first agent to be discontinued just because we are concerned about the risk of thrombosis. Okay, thank you so much for your time. I'm going to hand it over to Dr. Mann.
Just making sure, can you see my screen?
Yes.
So thank you so much, Marylee and Ashley, for that wonderful discussion on vasoplegia post-cardiac surgery. So for the remainder of the talk, I'm going to shift focus to a related topic, which is sepsis-induced refractory vasodilatory shock. So similar to vasoplegia, septic shock is characterized by profound vasodilation, which leads to decreased systemic vascular resistance and impaired tissue perfusion. One of the mechanisms that drives this is the production of nitric oxide and hydrogen sulfide, which are the same mediators that we've been talking about that are behind vasoplegia. This similarity creates the potential that some of the therapeutic strategies that Ashley covered might be applicable to treating refractory vasodilatory shock and sepsis. So I'm sure that you guys have seen from both Marylee and Ashley a similar flow sheet to this. The only thing I'll comment is that the difference in sepsis is you don't only have these inflammatory cytokines that are activated in the nitric oxide synthase, you also have lipopolysaccharides from your bacteria as well that activate this. They discovered this by actually utilizing animal models where they did either cecal ligation and perforation or just direct injections of lipopolysaccharides, and then measuring nitrogen oxide and hydrogen sulfide species or hydrogen sulfide amounts after that. And what they found is not only are they increased with this, that increased levels of nitrogen oxide and hydrogen sulfide actually correlate with the severity of your shock. So a smarter individual than I created a drug that actually blocks all nitrogen oxide. So it's a global inhibitor of nitrogen oxide. The drug was called LNMMA, and it was utilized by Lopez and her colleagues in 2004. And they did a randomized controlled trial of administering this drug to septic patients. And what they found was that although it increased MAPS and decreased vasopressor requirements, surprisingly, they had to end the study early because the drug increased mortality, which was not what anyone was expecting. And it kind of, unfortunately, caused some disinterest in utilizing or looking at this pathway for treating refractory septic shock. However, when they looked into it, what they found is that if you globally inhibited nitric oxide, that actually impaired some of the immune response. So what they found since then is that nitric oxide and hydrogen sulfide have themselves some benefit in killing bacteria, and they also induce macrophages as well. And so if you use a global inhibitor of nitric oxide, that's detrimental to your immune response and recovery from sepsis. So what some investigators started looking into, and what I'm going to hopefully try and cover with the literature, is utilizing things like Ashley mentioned methylene blue and hydroxycobalamin as adjuncts in refractory septic shock because they are further down the pathway and don't inhibit all of your nitrogen oxide species. And so you're looking more at that guanylyl cyclase inhibition of methylene blue, and similarly more of the hydrogen sulfide and scavenging some of the nitrogen oxide by hydroxycobalamin. All right, so methylene blue and sepsis. Similar to what Ashley found is there is some small data. There's a lot of meta-analyses of small trials combining both septic shock patients and surgical patients with some encouraging outcomes. But I tried to just focus on the studies that included solely septic shock and non-surgical patients. So starting off with this Kirov study, which is the first study at the top of the page, they took 20 septic shock patients and administered 2 milligrams per kilogram of methylene blue. And then they wanted to see if there was a ceiling effect of methylene blue infusion. So after that bolus, they did 0.25, 0.5, 1, and 2 milligrams per kilogram per hour of methylene blue at increasing doses every 2 hours to see if there was a ceiling effect to the MAP response. What they found was there was not a ceiling effect, so every increase in methylene blue increased the MAP with their continuous infusion. And they also saw a trend towards a decreased vasopressor requirement that was not statistically significant. The second study, the MEMIS study, started looking at cytokines and then also vasopressor utilization. So they utilized a 3 milligram per kilogram bolus over 6 hours. They found no difference in these cytokine levels, which they looked at, like interleukin-2, TNF-alpha, all of the common indicators that you could think of. So they found no differences in those, but they did find that during that 6-hour infusion, there was an increase in the MAP and a decrease in vasopressor requirements. This last study is the only randomized controlled trial that I can find with methylene blue in septic shock patients. This was done in 2023 by Ibarra and his colleagues. So they took a mixed medical surgical ICU population in Mexico and gave patients methylene blue 100 milligrams diluted into 500 milliliters of normal saline over 6 hours daily for 3 days. And what they looked at was vasopressor requirements and then also ICU and hospital length of stay. And then time on ventilator, and also just some laboratory findings of like what their creatinine was, liver function, PDAF ratio, kind of scoring like that. So what they found is they had 91 patients in total. So half of those had received that methylene blue dosing. And they found that those that had received methylene blue had 69 hours requiring pressors versus 94 in controls, which correlated to 1 more vasopressor-free day in the methylene blue group and a shorter ICU and hospital length of stay. They did not show any difference in any of the other secondary outcomes that I mentioned, such as mechanical ventilation or any of the other laboratory markers. The last slide I'm going to mention on methylene blue in sepsis is this is a meta-analysis that includes all of the 3 prior studies that I mentioned, plus 3 Chinese studies as well. So the first study is from Li and her colleagues in China. So they had 66 patients, half of which were given a 2 milligram per kilogram bolus of methylene blue over 15 minutes in septic shock patients. And then there was a Lu study, which they gave 2 milligrams per kilogram of methylene blue, but that was over 24 hours, and that was 54 patients in total. And then lastly, there was a study which is by Zhang. So this was the 6th study that was included. They are almost surgical patients. So they were septic shock patients that needed emergency surgery for their source control. And during the surgery, they infused 0.5 to 1 milligrams per kilogram of methylene blue, and this was in 40 patients. And these were the outcomes in those patients that you can see. There's some promising outcomes of short-term mortality, short-term mortality increasing with methylene blue, obviously vasopressor requirements decreasing, and then also duration of vasopressors and duration of mechanical ventilation improving without many adverse side effects. So there was no increase in methemoglobinemia. The only adverse side effects that this meta-analysis actually noted were blue skin discoloration and blue-green tint of urine. So again, I'll kind of comment on this in the conclusion, but as you can already tell, these are pretty small sample size numbers. I think a lot more data needs to be given for this to become mainstream. I just wanted to include this because it's thought-provoking, and I think hopefully in the future that there'll be a lot more literature coming out on this, because I think there's more and more literature coming out on this catecholamine resistant shock states, or where your adrenal receptor sensitivity is decreasing, and maybe we should be looking at these adjunctive measures rather than epinephrine as our third line vasopressor. So moving on to the other medication we mentioned of hydroxycobalamin. So the data for hydroxycobalamin and sepsis, unfortunately, is even more sparse. So commenting quickly on this first trial is by Sacco and her colleagues. This was done in 2021. So they gave refractory septic shock patients, which was defined as greater than 0.2 norepi equivalents, a dose of hydroxycobalamin 5 grams over 15 minutes. And then they measured their MAPS and vasopressor requirements at 1, 6, and 24 hours. And what they found was that there was a MAP increase and a significant vasopressor equivalent decrease at both 6 and 24 hours. So even though that bolus was only over 15 minutes, that it was sustained benefit from hydroxycobalamin. This Ritter study actually showed the opposite of that. They used that same hydroxycobalamin dose of 5 grams. They gave it to 35 septic shock patients. However, their refractory septic shock patients were a little later, I guess, in the course, or had higher doses. Their average norepi equivalent dose was 0.42. And in those patients, they found that the B12 or the hydroxycobalamin administration was not associated with an increase in MAP. The last study is, again, the only randomized controlled study that I could find for hydroxycobalamin and sepsis. This was done by Patel and his colleagues in 2023. So again, he used vitamin B12 with septic shock patients that were greater than 0.1 norepi equivalent. The average amount of norepi equivalents at the time of B12 administration was 0.3. And so they gave that 5 gram bolus over 15 minutes as well. And they found a 15% reduction in vasopressor support at both 30 minutes and 3 hours. So they found more of a sustained response in their patient population. And that is really all I have, honestly, for data for hydroxycobalamin and methylene blue in septic shock. As you can tell, like I said, these are smaller studies that have differing levels of methylene blue administration. So I think there needs to be further data on standardization of what methylene blue dose we're using. Is it bolus dose? Is it continuous administration? And then also for both methylene blue and hydroxycobalamin, deciding when are we giving this, when are we considering, this to be a refractory vasodilatory shock component. And then lastly, I think it would be helpful to have some better patient-centered outcomes as well with these septic shock studies. So not just vasopressor dose requirement reduction, improved patient outcome. I did like the study where it at least showed reduced ICU length of stay. I think that's at least somewhat patient-centered, more so than just a reduction in vasopressors. The other thing I wanted to comment on was angiotensin 2. So Ashley already beautifully covered the ATHOS-3 trial, so I won't go over that again. But I did want to mention the subpopulations that they are looking at from this ATHOS-3 trial. So specifically noting that there are some data showing that angiotensin 2 may have benefits, more specifically in those septic shock patients that are on renal replacement therapy, in those who have elevated renin levels. So if your hospital is capable of quickly running a renin level, it may be beneficial to send one in your septic shock patients that are rapidly progressing to 2 pressure shock. They noted a renin level of greater than 172.7, or if you want to remember 173. Those patients seem to have a greater clinical benefit to angiotensin II dosing. And then lastly, they noted that starting at those patients on angiotensin II that were at lower norepi equivalents, so they marked less than 0.25 as having better mortality than those at higher doses, which again just could be correlatory to how sick the patient was as well. But I just kind of wanted to note those subpopulations of the ATHOS-3 trial as well. All right, and then that's truly all I have about refractory vasodilatory shock. I'm kind of quickly moving through it. I wanted to hopefully end this discussion by using a patient case example and kind of what you would typically see of a patient coming out of a cardiothoracic OR and what vasodilatory shock can, or vasoplegic shock can look like. So this patient is a 65-year-old male who has a past medical history of chronic kidney disease, hypertension, hyperlipidemia, and diabetes. He has post-op a aortic valve replacement and a 3-vessel CABG. He unfortunately had a prolonged clamp and pump time, and also had some oozing postoperatively as well, which required DDAVP and some platelets. So remembering kind of what Marylee stated about risk factors, so the prolonged clamp and pump time increases the risk. You could state potentially the age, definitely his chronic kidney disease and diabetes all put him at risk for increase of vasoplegic shock post-cardiopulmonary bypass. The drips he's coming out on, the inotropic dose of epi is relatively high, and then on top of that, the vasopressor amounts are pretty high coming out post-cardiac surgery. So for these patients, initially, what I like to start with is just ensuring that these are not another form of mixed shock that's underlying this. So what I mean by that is, vasoplegic shock is somewhat a diagnosis of exclusion for me post-cardiac surgery. So especially with the increased chest tube output, I would want to rule out hypovolemic or hemorrhagic shock. So for that first hour immediate postoperatively, I'm really watching that chest tube output, probably sending some TAG values or ROTEM, whatever your hospital has for coagulopathy, making sure that I send coags, platelets, fibrinogen, seeing if there is any thing that I can replace to help with that coagulopathy. And then lastly, just really, like I said, trying to make sure that the patient's warm and that I'm correcting any other causes of that. So let's say for this patient case, for that first hour, there's not an increased chest tube output. So then the next thing that I would look to rule out is making sure that there's no tamponade. Things that would clue me into tamponade would be, first I would do a bedside POCUS, just looking for effusion around that heart, and then also looking at global right heart and left heart function. And then lastly, you also have the benefit of a SWAN in these patients. So if your PA diastolic and CVP are starting to approach one another, I'd be concerned about that. But again, in this case, let's say that's not what's going on. All those numbers are normal. And then lastly, I would like to rule out cardiogenic shock. So if I've already done a POCUS and the bedside ultrasound looks okay, then I'm just looking at my SWAN thermal dilution numbers, which are on the right here, look good in this case for the LV. And then for the right heart function, I like to look at a number that's called PAPI, which is your PA systolic minus diastolic divided by CVP. If all of those numbers look good, then pretty much, and I've already, probably given volume in this time amount, all of those numbers are then pointing towards vasoplegia. And then from there, I follow that algorithm that Ashley mentioned, where it's that stepwise approach, where I'm starting steroids for adrenal insufficiency, and then choosing either methylene blue or hydroxycobalamin. Usually that choice is based off of what the patient's home medications are. If they're SSRIs or SNRIs involved, then I'm usually leaning towards hydroxycobalamin. And then sometimes repeating that dose if there's not a good response in an hour, and then after that, looking towards angiotensin II. I know a lot of this data, like we said, is not the most robust or strongest, and I think that's actually kind of what I wanted to point out and hopefully make it be thought-provoking to you guys and just know that this data is out there. I hope you enjoyed this talk. These are our emails if you guys want to email with any thoughts, and if not, hopefully there's a few moments for questions.
Awesome. Thank you guys so much. At this time, we would like to open up for questions. I do have a couple questions already in the chat. I think we touched on it a little bit. Take a look. Okay. So first question, and feel free to enter your questions into the chat box below and I'll have them read out. Is there any evidence or any consideration as far as maybe combining methylene blue and hydroxycobalamin, or is it strictly a 1 to 2 if one didn't work, considering another agent?
Actually, there is a lot like of heterogeneity like in the data about patients getting actually both. So in some of the studies that have looked at hydroxycobalamin and in a lot of the case series, patients did get methylene blue and hydroxycobalamin. I think that's definitely an option. I will say in practice, I feel like sometimes people respond to one better than the other. But really they kind of work similarly. So in theory, if like one doesn't work, maybe the other one wouldn't work either. But a lot of patients have gotten like both in some of the studies and case series that have been published.
True. But nothing that we've seen as far as getting both at the same time that we know of. Okay. And then typically we're looking around the same 30 minutes to 1 hour to kind of assess the response and then pivoting, correct? Excellent, thank you. Another question. There was mention of ACE inhibitors being a risk factor for vasoplegia. How would you manage these patients in vasodilatory shock?
We typically hold, if we know that the patient is going to go for surgery, we'll hold for 48 hours beforehand to kind of reduce the risk.
Awesome.
The other part, I guess, from the septic patient portion of things, or like the medical ICU, is that's kind of where I was pointing out with that angiotensin II data. There's some thought process of actually sending a renin level, especially if they're on ACE inhibitors, because if that renin level is higher, they might respond to Ang2.
And then this actually kind of ties in a little bit. You touched on the ACE inhibitors. We also have other preoperative risks. Institution have other procedures or policies, protocols in place to identify those patients and maybe intervene to kind of reduce the risk thereafter?
I guess I need more clarification on the question a little bit. So are you stating for like identifying those who are like pre-admitted that are on like ACE inhibitors, things like that? Like, do we have policies to prevent that? I guess one thing I would state is we follow ERAC's protocol pretty religiously here, and so our anesthesia colleagues are wonderful at their pre-op assessment of those patients and making sure that they get their pre-op beta blockers, making sure that the ACE inhibitor has been stopped, that they've had their washout period from their antiplatelets. I don't know if that answers the question, but following basically the ERAC's protocol really helps make sure that a lot of those risk factors are negated.
Okay, I think that covers. We have, go ahead.
I was just going to say that we have, in the absence of a shortage where we don't have hydroxycobalamin right now, we have all of those agents available to in our OR pharmacy. And so those things are all readily available for people if needed. And so our anesthesia colleagues do communicate with the pharmacy downstairs to kind of make sure that they're aware that we might need these things, so that we're prepared if we do need something, we can get it quickly.
Another one, being in Georgia, we do see a lot of extreme weights to lower and higher sides. What dosing would you use for these? Well, specifically for methylene blue, what dose would you use? Actual, adjusted, ideal?
Well defined. Typically, if a patient is has a larger BMI, then I go on the lower end of the dosing range. I think if a patient has a really high BMI, you could consider using adjusted body weight, but I don't think that that's been really well established. But that's a great question.
And then the last one, unless something else may have popped up. Let me just open that one. Is there any concern with the use of hydroxycobalamin in AKI or renal replacement therapy and stuff like that?
Actually, I think you're on mute.
Me?
Yeah, there we go.
Okay. I was just saying that for patients that have that are going to receive methylene blue, there are dosing recommendations for patients with renal insufficiency. Those same dosing recommendations aren't there for patients that have received hydroxycobalamin, but there has been some stuff to come out about potentially hydroxycobalamin having an increased risk of acute kidney injury compared to methylene blue. So I think that's something that we're definitely thinking about, and I think it's something that hopefully in the next couple of years we'll have more data on. But I'm not sure that we have like the exact answer at this time.
The other thing I just want to comment on too, there was some of my reading with septic shock patients in the literature that I guess with hydroxycobalamin and the reddish tinge to like the urine, that it can with certain CRRT machines, not usually, I forget the not the green one, the green machine that most people use. I think it might be in the next stage one. I could be incorrect. That sometimes it messes with the sensor, but so just be knowledgeable, I guess, about that if your hospital doesn't have the, I don't know the correct term for it, sorry, the green renal replacement machines.
I do not see anything else in the chat. With that being said, thank you guys so much again for taking the time out and helping and educating our members on this talk. I hope to see again another strong turnout for our next bite-sized lecture where we'll be covering obstetric emergencies in the ICU. So please look out in your emails for those dates when they do come. And again, thank you again for coming, and thank you again for our speakers.
Thanks. Bye.
Thank you.